So, very good morning to everyone. So, first of all, I would like to thank Dr. Jayagotri and Dr. Dayakar for calling me and standing before in this Sunday morning. So, the topic is how to deal the external lesion from outside, that is not through the nose, from skin. So, there are this most debate topic. So, which is best, whether it is external or endoscopic or laser and so on. So what is suitable for the patient and what is best suitable in our hand, we have to choose without compromising the quality of care. And I would like to thank Dr. Raji for giving the detailed anatomy, which is easy to understand the surgical steps. So before starting the topic, I would like to thank the three mentors and Professor Radhakrishnan, who taught me not only the ABC of ophthalmology and all, he is straightforward to enough giving these cases from the day one. And this Professor Usha Madam and Dr. Santosh, from them, by attending the lectures last 20 years, I think way back in 2003, the first topic I attended Professor Usha Madam, as Dr. Venkatesh told, the retinoblastoma. So both of them, not only the pioneer in orbit oncology, they are leaders in orbit and oncology. So thank you, Madam, for shaping us, the future generation, what you can do for the best to your hand and best for the patient. So moving on to the 10 steps, why and how to deal for the successful and what is suitable in your hand and what you can do best for these patients with continuous EP4. So the basic understanding of anatomy here, pointer. So you know where you are operating. So Professor Radhakrishnan used to tell the orbit and the oculoplasty work, you have to play like a carpenter. So you know where exactly putting your knife and how much you can cut safely without compromising the physiological function. Nowadays, these orbit and even oculoplasty, apart from oculoplasty, even the orbital disease become a cosmetic in addition to the treating the disease. So the best outcome, even the patients so-called old age also patient. So the moment to tell about the visibility of the scar, the patient reluctant to undergo surgery in your hand. So it is, you have to assess and tell the outcome, like you are prescribing a progressive lens or multifocal lens. Lot of counseling is required. This is the most important thing before you decide for the surgeries, especially in external approach, whether you are operating young patient or the aged individuals. So know your anatomy and especially the neighboring structures. Without knowing that, if you put your knife, you are in trouble in middle of the surgeries or end of the surgeries. So what do you think about this patient? This patient came 1 week before to us with a chronic dacrocystitis. Anyone can diagnose the by appearance except our residents. She came to us last 10 years. His face is retracting, and she told that I was looking like a MGR before 10 years, and now my face is changed like this. He never gives any history of any trauma, any surgeries, but in our surprise, we see the investigation what it has shown in the later slide. Then diagnosis and indication. Most of the time, the patient comes with a discharge and watering. It can be due to various reasons. Dr. Raji told, like, elaborate what to investigate, what you have to look for. So a simple test, that is the rope loss, either by pressing with your fingers or simple buds. It gives a diagnosis when it is a straightforward case. The second thing, if you do proper syringing and if you interpret properly, I think most of the other investigations only for reserved for a small portion of your patients. So whenever there is a failed one, or if the patients have undergone any multiple facial trauma or previous surgeries or previous attempt by so on, those needs the special investigations. Remaining patients, these two things will enough to diagnose the diaphragmatic cystitis. And when you want to do the simple external DCR. So when the patient comes to you with the step management for congenital nasal duct obstruction, like probing and intubation, if everything fails, then you plan it for. Or the primary acquired nasolacrimal duct obstruction and secondary nasal duct obstructions without any canalicular or common canalicular injuries, you can do this external approach without additional procedures. The history and examination is very, very important. She told anything because the epiphora can be a combination of both. It can be due to your dacrocystitis or can be due to the associated, or sometimes it may combination of both. So always look at the lids, whether the puncta is visible or not. If the punctum is visible, if you do the surgeries, the disease gets treated, but the patient primary complaint of epiphora is not getting addressed. So you have to look at this and correct both and tell the patients we need the correction of the associated factors also. And also look at the facial palsy if there is any. Sometimes in during recovery phase, the patient will have epiphora. So unless we address these things, if do the end up in surgery completing the DCR, you will be in trouble and patient will keep on coming. Your surgery is not enough to control the tears. And most important thing, look at the neighbors and what you have to do. So as a primary ophthalmologist, not even orbit and oculus, any patient comes to you, at least examine the nose with a torchlight with nasal speculum. If there is any polyp or any inferior turbinate, although we get the opinion from the ENT surgeons, examine this and what you want from them to address your primary disease. So if you don't treat this, straightforward you go there and you end up in intraoperatively with the bleedings, or if there is any mass, you missed it and it can extend into the orbital cavity and you making this disease spread into the orbital cavity. So always look at this, correct this associated pathology before you dealing with the external DCR. And investigations, as an ophthalmologist, we do restrict our investigations, especially for if you have anterior segment surgeons. So make sure that these patients got in, especially after COVID, even the patients less than 40 years, many of them presenting with ischemic disease. Don't underestimate the ischemic conditions in the young individuals. Many of them, even at the 30, they are going for primary angioplasty as well as the stent. So look at this, even without any ECG changes, always get the primary physician opinion and fitness before you tackle these patients, because we use this adrenaline packing as well as the injections. So these patients, so face is looking normal, you need not much investigations, especially the radiological imaging. So the next patients, we have the abnormality in face. If the patient gives any history of trauma and other things, following which the patient develops watering and epiphora, it is essential to subject the patient for radio imaging before it, because the normal anatomy is misaligned. Then you have to know where exactly you have to do, or whether already the abnormalities have been corrected, is there any implant and so on. This is what this patient CT showed with the multiple fractures and even fixations for the mandibles. So by patients absolutely denying that any trauma and undergone any surgeries, even he had a fractured femur, so polytrauma, following which he lost his memories, and this is what we have to do. Then DCG is in case, especially when you suspect canalicular obstruction or in cases of failed DCR, you have to do this. Otherwise, routinely this DCG or any CT or MRI guided imaging is not required unless the patient is having patient is failed DCR or patient previously undergone DCT. You want to control the epiphora, or if there is any facial bone anomalies or abnormalities, you have to do this. And preoperatively, so many of the time this allergic rhinitis and other things are very common. I think ENT sir has come. So a lot of patients comes with the nasal congestions. So you have to control this so that when you make the flap, the bleeding can be minimized. And second thing, many of the old textbooks and the study shows when you operate upon the female in reproductive age growth, generally we have to avoid the surgeries during the menstrual cycle and ensure that the patients, even sometimes patients taking the anticoagulant, they may not tell to you. When you retrospectively ask, you didn't ask, that's why we didn't tell. So it is our duty to have the checklist before touching upon these patients or planning for surgeries to inquire all these medications, especially the anticoagulant, whether in the oral or in injectable forms, and ensure that with the consultation of the primary care physicians to stop at least 5 days before, especially the clopidogrel, which can cause intraoperative uncontrolled bleeding. The incision is very, very important. First, already mentioned, you have the angular vein around 5 to 8 millimeter from the medial canthus medially. So you have to avoid injuring this. So it doesn't matter when you injure it, but the amount of outcome. So if intraoperative bleeding unpaid and you will be getting stressed. And also the scar outcome, when you have a lot of bleeding intraoperatively, the scar will be more. So you have to make sure that you avoid injuries and the injection site. So this is the one we had the single, what is called single prick injection for the DCR anesthesia, which I have presented in during the ocular anesthesia conference held in 2011. So for which we won the second prize. And adequate nasal packing is very important, which causes, if you don't pack it properly because of the associated DNS or hypertrophy of the turbinate, you have heavy bleedings intraoperatively. And the bicanalicular indication is not required for all cases. Whenever you have small sac or when a patient is having a suspected partial canalicular obstruction, you need this. Otherwise, routinely it is not required to intubate these patients. So intraoperatively, so incision, so you can make a curvilinear or along the lower lid trough, you can make the incisions so that it merges with the skin folds there. And the ostium size, we have to opening at least a minimum of 1 to 1.2 centimeter size. The ostium, if you make small irregular edges of the ostium, which lead on to failure of the, one of the cause for the failure of the TCR is the small ostium. And also the edges of the bone opening should be smooth. This is another thing which many studies prove that if you have the osteophyte growth will be more if there is a irregular edges at the ostium opening. And the next thing is if you make the flap, the anterior flap should be larger than the posterior. It doesn't matter about the outcome or success, whether you close the both anterior and posterior flaps. You have to usually excise the posterior one and make a larger anterior flap and close it without any gap. Regarding the closure of the subcutaneous tissue, so you just opposite the orbicularis. So need not suture the orbicularis again. So it produces sometimes bleeding and causes scarring and studies have been proved. So just to approximate the orbicularis and suture the skin. That is alone enough with the monofilament single sutures. And post-operatively use the nasal decongestant for at least 2 to 3 weeks so that repeated inflammation of the mucosa can be or congestion can be avoided, and sutures can be removed from 6th or 7th post-op day. And when you do this, because we had one of the patients went to local practitioners, the bicanalicular intubation have been removed because of the ocular irritations within a week. This lead on to the failure of the DCR. So instruct the patients what you have done apart from the suture removal, how long the canalicular has to be kept before it is removed. So it is not that all the patients will have visible scar. These are the few patients we can just see like a fold is almost completely near to the normal skin. So that is how we have to make a sutures, either subcuticular. Even nowadays, the steady strips available. So when the patient will maintain adequate aseptic precautions, we can use the steady strips also. These are the few studies about the suturing the skin with subcuticular as well as the steri-sips, and steri-sips gives a better cosmetic outcome than the even the subcuticular sutures. And regarding the double flap or single flap anastomosis, the end results will be the same. So the outcome success based on how large enough you make the flap and ostium and how carefully you close the wounds. The most important in today's world is the documentations. Any procedure you do, document and mention all the complications which you expect in even the experienced hand. Because nowadays patient, if you don't mention, it is considered as it is not talked to or explained to about the patients. You can use the very well documented and consent form which is available in AA's website for most of the ophthalmic and other procedures. You can use that and modify it according to your need. So this is how the patients immediately after looks. If you look at under local anesthesia, if you do the proper anesthesia technique, it is painless for both the surgeon as well as the patient. And if you are not able to produce these painless surgeries, intraoperatively have pain, it will causes raise the BP not only to the surgeons and also to the patients and other things. So always decide in your hand and which is suitable, what kind of anesthesia and what kind of techniques favors for the patient for the better outcome. So to conclude, so understand where you are working and the selection of case, which technique and which additional procedure like intubation and other things required. And before touching upon these areas, have adequate training and suturing the anterior mucosal flaps and adequate ostium opening, and wherever required have the cross consultation, especially sometimes this patient develops nasal synechia following surgeries. So have the consultations, especially with the ENT, and document what you have done for the patients, because after sometimes 5-10 years patient can come with a failure. You should be able to know what you have done previously, and if you want to refer somewhere, document what you have done to the higher level. With that, I conclude. Thank you. So nothing is impossible in your life. Everything is possible. Don't think it's a DCR is a major surgeries. If you have adequate understanding, adequate experience, you can very well do it at your own. Thank you.